In this next section, Chemotherapy I, we will go over certain types of chemotherapy medications, including antimetabolites and alkylating agents. In this section, we'll begin to discuss chemotherapy. Most anti-cancer chemotherapeutic agents have their greatest effects on rapidly proliferating cells, other than simply the cancer cells. And these rapidly producing cells include the bone marrow, the GI tract, hair, gonads, and skin. We will talk about a number of different classes of chemotherapeutic agents today, shown here. With regard to chemotherapy toxicity, it's important to know dose-limiting toxicities of individual agents, but a common problem among most chemotherapy agents is bone marrow suppression, and that includes neutropenia, thrombocytopenia, and anemia. Patients that have neutropenia are at increased risk for infections. In some patients, we can treat this with G-CSF or GM-CSF, which are colony-stimulating factors of the bone marrow. Some patients, it's impossible to give these, however, especially leukemics and lymphoma patients, because these may actually worsen lymphoblastic leukemias and granulocytic leukemias. Thrombocytopenia is another problem in patients that have bone marrow suppression. These patients may have increased risk of bleeding. We can give these patients platelet transfusions. Other patients may develop anemia that can cause severe heart problems. We can treat these patients with erythropoietin or packed red cell transfusions. We never give patients whole blood transfusions anymore. We only give packed red cell transfusions. Antimetabolites are a classification of chemotherapy agents that are cell cycle specific. They disrupt DNA synthesis in the S phase, or the DNA synthesis phase. Some examples of antimetabolites include methotrexate, 6-mercaptopurine, or azathioprine, cytarabine, or Ara-C, and 5-fluorouracil. Here's a diagram of the cell cycle. Quiescent cells live in G0. When a cell needs to divide, it will enter G1, which is a growth phase, and then it will enter S phase, or the DNA synthesis phase. After DNA has been replicated, the cell will enter G2 phase and then enter mitosis. It's during this phase that the cell will divide into two separate cells. Certain cells live in G0 for a long time, including neurons and cardiac myocytes. They're not able to divide very well, whereas other cells, for example epidermis cells, are able to. Some cells are able to become quiescent and then divide, such as hepatocytes. The mechanism of action of antimetabolites is to interfere with metabolic functions of folic acid, purines, and pyrimidines. Methotrexate's method of action is to inhibit dihydrofolate reductase. This medication is used for some leukemias, as well as breast cancers, lymphomas, and choriocarcinoma. This medication is also used for severe rheumatoid arthritis and psoriasis. Adverse effects of methotrexate include, obviously, bone marrow toxicity. It can also cause crystalluria. This medication can also interfere with folic acid synthesis. Leucovorin, another medication that is also called folinic acid, is an antidote or rescue medication for patients that have methotrexate toxicity. Leucovorin rescue is generally not needed for patients that are taking lower doses of methotrexate for rheumatoid arthritis. This is a diagram that shows methotrexate concentration in the bloodstream in the y-axis, and in the x-axis you have hours post-methotrexate dose. And as you can see, as you increase the dose of leucovorin that's given to these patients, you see a decrease that's concomitant over time of the plasma methotrexate level. 6-mercaptopurine, or 6-MP, is the actual active agent, whereas azathioprine is a prodrug that is converted to 6-mercaptopurine. This medication works by inhibiting purine metabolism. If a cancer cell is coming in contact with this medication, it can cause interruptions in DNA synthesis. This medication is activated by HGPRTase, the enzyme that converts 6-MP into the active form. This medication is generally used for acute leukemia. The adverse effects of 6-mercaptopurine include bone marrow toxicity and hepatotoxicity. Patients that have a genetic deficiency of TPMT, which is an enzyme that breaks down 6-mercaptopurine, would be prone to severe adverse effects. The use of allopurinol actually can lead to 6-MP toxicity as well. Azathioprine, which is a prodrug and has a high bioavailability, is converted by GST, or glutathione S transferase, into 6-MP. 6-MP is then activated by HGPRTase into thiopurine nucleotides. These are the active anti-tumor metabolites. 6-MP is also inactivated into safe metabolites by thiopurine methyltransferase and xanthine oxidase. Allopurinol should not be given because it can inhibit this pathway, and some patients have a genetic deficiency of TPMT, which will block this pathway. Whereas these thiopurine nucleotides are active anti-tumor metabolites, they can also be toxic if they're in high quantities. Cytarabine, or Ara-C, is another anti-metabolite that is activated by tumor cell kinases, and it works to disrupt pyrimidine metabolism. Tumor cells that don't have these enzymes will be resistant to the therapy, meaning that Ara-C will not work in these patients. Ara-C is used a lot for acute leukemias, and its main toxicity is immunosuppression, or neutropenia. 5-fluorouracil is a medication that is converted in the body to fluorodeoxy-UMP, a fake nucleotide. And this medication will compete with DUMP for the enzyme thymidylate synthase in the tumor cell, and thus will inhibit DNA synthesis. Resistant tumor cells have altered thymidylate synthase that's not able to bind to the fluoro-DUMP. 5-fluorouracil is used for a lot of solid tumors, including colon and breast cancers. The main toxicity, again, is bone marrow suppression. It's important to remember that leucovorin may also increase 5-fluorouracil effects, which is the opposite of its effect on methotrexate, which it can actually decrease the toxicity of. The next category of medications that we'll talk about are the alkylating agents. These agents are cell cycle nonspecific. They're able to covalently alter DNA bases, usually at the N7 position of the guanine nucleotide. These agents can cause cross-linking of DNA strands, abnormal base pairing, and DNA breakage. The first two compounds in this category are cisplatin and carboplatin. These medications contain platinum, and they're used commonly for the cancer of the testicle, specifically the non-seminomatous germ cell tumor, which is very sensitive to cisplatin. Seminomas, however, are not responsive to cisplatin and carboplatin. These are usually sensitive to radiation. Other tumors that we can use cisplatin and carboplatin for are bladder, lung cancer, ovarian, and colon cancer. Adverse effects of these medications include nephrotoxicity, which you should try to avoid by hydrating the patient quite well, and ototoxicity. Cyclophosphamide is another alkylating agent that is activated in the body by cytochrome P450 enzymes. This medication is used for breast, ovarian, and non-Hodgkin's lymphoma. Cyclophosphamide, again, can cause bone marrow toxicity. The characteristic adverse effect of cyclophosphamide is hemorrhagic cystitis. Cyclophosphamide is converted to a toxic metabolite called acrolein, which can damage the bladder. Giving a patient a drug called Mesna, or 2-mercaptoethane sulfonate, to trap the acrolein can actually protect the bladder from this damaging molecule. This diagram shows the metabolism of cyclophosphamide after it's digested by the body. Cyclophosphamide is converted in the liver by cytochrome P450 to these intermediates, including 4-hydroxycyclophosphamide, which is converted to aldophosphamide. This can be converted by oxidation to carboxyphosphamide. It is also non-enzymatically digested into the active metabolite, the phosphoramide mustard, plus acrolein. Acrolein can damage the bladder, whereas this is the active anti-tumor agent. This concludes Chemotherapy I. In our next section, Chemotherapy II, we will go on to discuss some other types of chemotherapy medications.